Well, good afternoon, everyone, and thank you for joining us for our Meaningful Use Stage 2 and Health Information Exchange webinar. My name is Sean Kennedy. I'm the Director of Health Information Exchange here at the Massachusetts eHealth Institute, and we've got some great information to share with you today and some really wonderful speakers who will impart their knowledge and some of their experiences with you. So we have a number of things we'd love for you to be able to walk away from this presentation being able to do. Being able to describe the transformational intent of meaningful use and increased trend toward interoperability of meaningful use stage 2, name the meaningful use objectives with an HIE component and define their meaningful use 2 measures, describe the approaches to achieving the transitions of care and view, download, transmit objectives, name the available public health registries that indicate their current status and submission pathway, and describe how to find a trading partner and best practices to engage in. And to accomplish those objectives, we've got an agenda that we've set forth, and we know this is a pretty aggressive agenda. There's certainly a lot of information to cover, but we think we've architected this well enough that we can get through it all in 45 minutes. The first, we'll talk about the meaningful use 2 objectives with an HIE component, and we're going to focus on the measures and documentation for transition and care and view, download, transmit only, even though there are more that require exchange of information. We're going to describe some approaches to achieving transition of care and view, download, transmit objectives. And we're going to have some speakers share their experiences. So we have Sandra Rondell from Lung Specialists of Merrimack Valley, who are representing the eligible providers, and then Bill Housen from Signature Healthcare, representing the eligible hospital side. We'll then do a quick overview of the meaningful use eligible public health registries, and then I'll spend a few minutes talking about finding a trading partner and best practices to engage in. So our speakers for today, you can see myself there, Al Robleski, who is the Client Services Relationship Manager here at MeHI. Sandra Rondo, again representing the eligible provider perspective as a practice administrator at Lung Specialists of Merrimack Valley. And Bill Housen is the Clinical Systems Analyst at Signature Healthcare, and he'll be representing the eligible hospital perspective. So we recognize that there's a lot going on, and that's probably an understatement. There are enormous demands placed upon each and every you. We certainly recognize that. And we're in this period of transformation where meaningful use is working to accelerate that transformation through its 2, soon-to-be 3-stage meaningful use program. Where meaningful use 1 set the stage for exchange of structured data, meaningful use 2 really and specifically focuses on interoperability. So we've got this new novel relationship between CMS and ONC, where you see this really tight and frankly frequently confusing interplay between the meaningful use objectives and measures and the ONC certification criteria. But it's all in an effort to improve the quality of care, through improved care coordination as an example. And that care coordination applies interoperable EHRs. So you may have heard that ONC describes interoperability, and they certainly have a big vision statement they've set forth for interoperability, and they describe it as this concept of exchange, but also use. It's not good enough just to send information from point A to point B. You have to send it in a way that they can use it on the other side. And there's 2 components to that. You've got the content and the transport. So from a content perspective, being able to create and display structured documents. You may have heard, and if you haven't, you soon will, of the consolidated CDA, certainly a big requirement, essentially a container that maintains a lot of templates. And then transport in the requirement for direct messaging. Again, if you haven't heard of that, it's certainly something you're going to become intimately aware of, and there are some options that are included there. So we recognize that this is really a pretty confusing environment, but we like to think that MeHI here is really here to help and help support this real-world interoperability. MeHI was founded about 6 years ago, and we're a quasi-government agency, and our job is to promote the adoption of health information technology. So all this business around meaningful use, implementation of EHRs, exchanging via HIEs, these are all areas that we have experts that can support and help, and you'll hear from a few of them today. We have a couple new initiatives and programs that we'll be launching to really support this big interoperability effort and the adoption of health IT. There's an e-health services and support effort that we have or we're launching here. You're going to hear more on that shortly to really encourage that effective use and to support our meaningful users as they work to get through their various stages. And then we have a big program that's going to be kicking off shortly called our Connected Communities program, where we recognize there are these natural referral circles that exist in the communities, and how do we help them? How do we promote their exchange of information so that they can improve care coordination for their respective populations? And this is all done so that we can support the larger state reform efforts. Chapter 224 was some legislation that came out in 2012 that really pushed the envelope on cost containment, reducing cost in healthcare, and it's one of many things that are going on here in Massachusetts, areas that we're eager to support each and all of you on. So look at MeHI as a resource as you're moving forward, and let's go ahead and just dive into our presentation here. So with that, I'm going to go ahead and turn it over to Al Wroblewski, and he is going to share a little bit more with you about Meaningful Use 2 objectives with an HIE component, objectives, measures, and documentation. And again, Al is one of our client service relationship managers here at MeHI.
The whole idea of the HIE component is really data exchange outside of your organization. It's really moving it outside of your own internal system. And that's an important piece. For example, if you have a after-visit summary and you're transmitting that to the patient portal, most likely that's not going to require a health information exchange. Most likely that'll be an internal process. So we're really looking at going outside the scope of information technology that you control. Objectives, measures, documentation, a key element, and Sean alluded to this, which makes my work particularly challenging, is CMS uses those terms somewhat interchangeably, objectives and measures. The objective is what it is you want to achieve, and if you look at the table of contents for stage 2 or stage 1, it calls them objectives, and then when you turn to the specification sheet, it'll call it a measure. So unfortunately, that's very confusing. But I like to look at it, the objective is what it is you're trying to achieve. The measures is the means by which you achieve the objective. So if you fulfill the measures, by definition, you will then achieve the objective. And the third one, documentation, is a key element in all of this, as everyone knows. And so I'll put some energy into addressing that as well. So some of the objectives with an HIE component, and actually many of them have it potentially, as the health information exchanges sort of get built out and they have more functionality. But the two that we're going to focus on is the transitions of care, and that's also known as the summary of care. The view, download, transmit, which is electronic access, patient electronic access, more commonly considered the portal. And then Sean will spend a little bit introducing us to the health registry submission. The last three we're not going to address at this point: e-prescribing, lab results, secure electronic messaging. So what we're really looking at is the environment is shifting beyond the EHR. I guess that's the main message of today's presentation, and that the idea is to really embrace that and to know that's in a way part of the plan, to really expand beyond the individual EHRs so that there is this increased level of reliability and connectivity. So one of the things that came up this year, based on a lot of feedback from vendors and people in the field, IT folks, is that the ability to implement all of these new systems, especially the 2014 edition, were really much more challenging than anticipated by CMS and ONC. So there currently is a proposed rule which would allow some flexibility in how people attest in 2014. Essentially, if you don't have your 2014 version, you can still use the 2011 certified, but you would not be able to attest to stage 2. It would have to be stage 1. If you do have the new 2014 version, you have an option of attesting to stage 1 or moving forward to stage 2. The advantage of going to stage 2 is that January 1st, if you're in your second year for meaningful use in Medicaid, or your third year for Medicare, you do have to do a 365-day reporting period for stage 2. Here's a little schematic I put together how to approach meaningful use, and I suspect many of you are already pretty much following this methodology. But number one, I believe, is a really important one, that look at these objectives in the context of your own organization. One of the challenges I've seen people sort of almost create for themselves is they see these objectives as CMS's objective, or ONC, or somebody else. It's not for the benefit of the practice. And what I encourage you to do is to think of them as opportunities to utilize the new processes, utilize technology to benefit the effectiveness and success of your organization. So yes, it is a requirement of CMS, but try to own that. Try to take it on as a way that it comes back to improve the work that you're doing. The second one, and this is one particularly challenging for the smaller practices, where you actually are beginning to look at policies, procedures, workflow, and in some ways you could say this is a process approach. So part of this is to really think of it as a process. It's not event-driven. It's not transactions. It's not a one-time thing. It's really about creating a process. The third one, align that with meeting the meaningful use measures. The fourth one, do what's necessary to meet the measures. That may seem totally obvious, but as many of you know, to retrain staff, to really educate people that what you have to do has to, in a way, contribute to the metrics that will demonstrate you've met the measures. Capturing the evidence, generating and storing credible documentation. And then the last two, again, leverage technology to achieve objective. And if you'll notice, I did not use the word EHR or certified EHR. I used the term technology because that's what this is all about. There's more components to leveraging technology than just the certified EHR. The last one, improved interoperability. There are two sides to it. There's the sending side, which is where the metrics are predominantly. But there's also the receiving side. If you're a great receiver of referrals from a technological point of view, there may be the consequence that people like referring patients to you. So look at that as even though the measurements don't really reward being a good receiver, from a practicality point of view, if you're good both on sending the documentation, putting it out there in an effective way, and then also receiving, there are great advantages for your practice. Okay, we're going to move through these quickly. I'm assuming people are somewhat familiar with the specific objectives and measures. Again, if you look at it, the objective is what you want to achieve, and the measures are, it's the doing. That's the process. Are you, in fact, doing the activities that will demonstrate that you have successfully met these measures and then achieve the objective? And this is for the EP summary of care. Next. View, download, and transmit. One of the points I want to emphasize here, which is very, very subtle, if you look at the objective, it provides patients the ability to view online, download, and transmit, which means the technology has to have that functionality. If you look at measure 2, the 5%, more than 5% of unique patients view, download, or transmit. Notice the or. So you can pick from any one of those three. But the first one is you really have to make sure that the capability, the functionality is available for all the patients. Okay, and on the hospital side, very, very similar. The summary of care is essentially identical to the what you have for the EPs. And the download, transmit, a little bit different because you're dealing with discharges. the turnaround time is a little quicker, 36 hours versus 4 days for the EPs. Documentation. I also like to use the word memorialize, sort of like Mount Rushmore, where you really are very conscious of retention of proof that you have in fact carried out the measures properly and correctly, and that it's open to scrutiny should there be an audit or in terms of attestation that you need supporting documentation. The second bullet point is like we're moving into new territory here. The interoperability documentation is a new frontier. It's really all about, again, training partners, which Sean will address, but it's also getting very reliable verification that whatever content has been sent or transmitted has in fact been received or viewed or used or somehow accepted on the other end. And this is one of the real key points of a trading partner, that they're sensitive to the documentation requirements and are cooperative in terms of helping you generate metrics that show that you have in fact carried out a successful transmission.
That's great, Al. Thanks a lot. I appreciate you sharing that with everyone. So next we're going to move into our approaches to meaningful use 2. And we invited 2 guest speakers to join us today to share their approaches, one from the provider perspective, one from the hospital perspective. And our first one is Sandy Rondeau. She's a practice administrator at the lung specialist in Merrimack Valley in Lowell, Massachusetts. Lung specialist is a well-established pulmonary critical care and sleep medicine private practice serving the greater Lowell area. Sandra successfully implemented a fully functional electronic health record in July 2005, was an active member of the Physician Hospital Organization's selection committee, encouraged community participation by providing on-site, hands-on visits to the practice, and continues to be proactive in moving the practice and community towards MU2. Sandra has worked in the healthcare field for over 30 years and a member of the Professional Association of Healthcare Office Management. So with that, Sandra, perhaps you can share with us what you're doing at Lung Specialists in Merrimack Valley.
We are utilizing eClinicalWorks version 10, which is a comprehensive electronic health record and practice management system. Along with their comprehensive EHR, we are also utilizing their patient portal, and we are utilizing their peer-to-peer, which stands for physician-to-physician communication. We activated actually the peer-to-peer back in 2010, and I'll talk a little bit more about that. We also began exchanging with a non-ECW physician who is actually using EHR called ComChart through Join the Network or Peer-to-Peer Open, which is an open free platform for providers. In the fall of 2012, we sort of thought a little bit beyond physicians, because as a specialist, oftentimes you don't refer to another physician. So we thought about, where do we send our patients? Because we're a pulmonary and sleep practice, which is a big part of our outpatient practice, we tend to send a lot of patients to durable medical equipment companies for oxygen and for CPAP. So in the fall of 2012, I really concentrated on working with our vendor to allow key DME providers who I thought could handle the security around having access to the information electronically through the peer-to-peer open to come aboard. In April of 2013, I was hesitant, but I did make the move to the cloud. So I let go of my in-house server and all the security that comes with having that in-house and let it go out to the cloud. I'm happy to say a year later, I am very satisfied that I made that transition. This spring, I applied with eClinicalWorks for our direct address so that we can move to the next level of exchanging information with providers with other EMRs. Our PHO is actually actively working with eClinicalWorks as a vendor. They happen to have a big presence here in this area, so the PHO is also working with them for that interoperability piece. So I'll talk a little bit about what we've done for the VDT, as people call it. It took me a while to get used to that. We also have an ID physician here, so when people said VDT, I sometimes thought of diseases. But for that view, download, and transmit, back in November 2013 within our EHR, we have the ability to change the settings. So everyone was always hesitant in the specialist world to let results go out there for many reasons, because most of our results are not routine screenings. So we had that sort of everything by default was don't publish to the portal. So we had to let go of that. We changed that in November 2013. We're allowing things to publish to the portal automatically. It's taken a lot of education, both to our providers and our clinical staff, to let them know the importance of posting a result with information that's actually meaningful to the patient. So you want to make sure if you're posting a result that's not a routine screening and it's got a simple negative positive result, that you put some information along with that result so the patient can understand it. I also stress to all the physicians and staff that the hospitals, and you'll hear a little bit about that, also have to meet some of these measures. So the hospitals are starting to release information as well. So you may need to deal with the fact that your patients are getting information before you've even released it to them, because it's been released by the hospital to them. So you want to think about that, and how you might want to handle those calls inside your facility, so the workflow process. We started to let the patients know. So every time my office happens to be outside, right outside my checkout station. So when the physicians bring the patients and I hear them go, "We're going to call you," or "Call me," sometimes I'll go up and go, "Oh, Mrs. Smith, you're enabled on the portal. So Dr. Lynn, instead of having Mrs. Smith call Mrs. Smith, you're comfortable with replying to us via the portal." We've started to do that over the past, just recently, the past couple of weeks. And what I'm hoping is that that's going to prompt the patient when they get that email, your physician has posted a message, it's going to prompt them to log into the portal and look around. So now they start looking around and they start viewing things. So now they've kind of met your V part of your VDT. They are viewing. So you've met one portion of that. I've seen the numbers inch up a little bit. So we're trying to hit sort of that percentage, that 5% they're looking for, and I'm almost close to 3. So I'm hoping we can meet 5. So we're encouraging staff. I'm encouraging staff when patients call, let the patients know ahead of time that the provider is going to reply via the portal, working really hard with my providers to do that. So that's sort of how we're prompting people. Now, if that should fail, my other recommendation is I'm going to enter all patients who submit information to us via the portal. I'm going to enter them in a drawing for a free iPad, hoping maybe that'll pique some interest. So I'm going to watch the numbers, and we kind of laughed about that and put it to the side burner, but that may be a reality. That might be what it takes for patients to sort of go in and look around. The other thing that we're doing is eClinicalWorks also has a HELO application, and you'll sort of see that on the slide if you want to check that out. That's also a way for patients to take their different portals, if other portals can belong to HELO besides eClinicalWorks portal. Take those portals and tie them together, either on their computer or their cell phones, so that they can have one single login, username and password, and tie all those portals together. Because I think some of you will agree with me. I think patients are going to get sick of having 3, 4, 5 portals and everybody's forcing information. A lot of username and passwords to remember. So the HELO app, I'm actually going to play with it. I now have 2 portal accounts personally from 2 of my physicians. So I'm hoping to play with that in the next month and see if I can tie those accounts together and see if it works a little more seamlessly there. So as far as that's kind of my summary of the VDT. Now, if we talk about transition of care, this is a big one for specialists. So I did a little bit of digging before this seminar, and I have confirmed, at least with our EHR vendor, that if you are a specialist and you are electronically submitting or faxing your consult note to the primary care physician, you will receive credit under Measure 1, because Measure 1, you can be sending that information in any format. So you can be faxing it or electronically submitting it in Measure 1. And again, as was mentioned earlier, keep in mind that it's a transition of care or referral. So specialists panicked over this a little bit because they thought they were going to have to be doing all these referrals, which they don't do because they usually send it back to the PCP. But it's really you're transitioning the patient's care from you as the specialist back to the primary care physician. Thus, you're supplying the primary care physician or whoever the referring physician was your consultation note. So that will count. The other thing to do as a specialist, again, I mentioned a little earlier, look beyond traditional providers or your traditional referrals. Think about where you send your patients. Do you refer them to other entities? Again, for us, we've got that durable medical equipment piece. We also have dental providers that we may refer to for physicians to get dental devices for sleep apnea. So think about beyond providers, where do you transition your patients to? For those providers, you can set up outgoing referrals, and you can send it via fax or electronically if you want to get those providers of care to join the network, the peer-to-peer open network. It's a free platform, and you can exchange information that way. That has worked, I can't tell you how well, for our durable medical equipment companies. Those that I've allowed to come aboard cannot thank me enough. It's made a big difference in their workflow. So think about that. The other thing that I would say is, again, it's a balance. And so as you go through these measures, you try to set things up so that you're transitioning, sort of as Al stated, you're transitioning to meet the objective, but you got to find a balance initially to sort of meet the objective to get through your meaningful use attestation, but then you're going to build upon it. So you're not going to be done just here. You're going to be building upon it. And when you're talking about transition of care, I'm hoping that both primary care physicians and specialists are training the staff. The biggest roadblock we've run into here in the community is that providers are sending information through peer-to-peer as part of their workflow. So instead of faxing, they're sending it electronically. But unfortunately, it's sitting at the primary care office somewhere because nobody knows how to retrieve it, or it's sitting at the other provider, the referring provider, because nobody knows how to retrieve it. So this is not just a physician function. All staff members should have access to the information that's coming and going electronically. All staff members should be trained on how to pick it up, how to import it into your system, and how to use it. There's a nice CCR CCD portion to that where we can import current medications and allergies. Make sure your staff is trained, because I go out to offices, I'll go to train them, I look under their information where it should be coming in, and there'll be 50, 60 records sitting there from 6 months ago. No one even knew they were there. So it's really important to train the receiving side where that information is coming and how to import it into your system. And again, look, this is long-term, this is not short-term. Like Meaningful Use Stage 1, we all scrambled to sort of meet the objectives. Now, and as we go forward with Meaningful Use Stage 2, it will get easier, and we'll sort of expand upon it and keep moving forward and keep making the workflow better. I'm a big believer. I know a lot of us have heard with Meaningful Use the term checkbox medicine. I'm a big believer that although we have to meet these mandates, they are required, that if you really look at your office workflows, that at least you can truly make them meaningful within your practice. So you want to be putting information out that means something to the receiving party.
So now we're going to switch over to Bill Housen. And Bill is with Signature Healthcare. He's been working with Signature Healthcare for over 10 years. The last 3 as Clinical Systems Analyst and Meaningful Use Specialist. Primary responsibilities include coordinating meaningful use for both eligible hospital as well as over 100 outpatient eligible professionals.
So just let me give you a quick overview of sort of the ecosystem that we have here at Signature Healthcare. We're an integrated health system, so we have both a hospital and an ambulatory environment. For the hospital side, we're using MeHI, which you can see over there on the left, the eligible hospital there. On the ambulatory side, we're using Allscripts. Both of them are connected to the same HIS up there at the top. We use the MedAllies HIS instead of the Mass Highway for the moment. I'll come back to that more in a few minutes. And we're doing that through direct messaging for the transition to care measure. Down at the bottom of the screen there, you'll see the patient portal. We use the Follow My Health product, which has since been acquired by Allscripts, but we really wanted to have one portal there for both sides. And I'll circle back to that in a second. I just want to note that we here at Signature Healthcare, we had both Meditech and Allscripts in place and being utilized before Meaningful Use came around, which I think made the start of our Meaningful Use journey a lot easier. We didn't really have to start from a paper-based system just to meet these requirements. We already had systems and workflows in place. We really just sort of modified those to really meet the intent for the Meaningful Use requirement there. The ambulatory patient portal went live, I think, in early 2013. I want to say March or April 2013. And the hospital joined in spring of 2014, so just earlier this year. Let's see if I can hit the next slide here. There we go. I'm going to focus specifically on the hospital side here, but this is an example of our Meaningful Use dashboard for the acute side. We ended up purchasing a third-party sort of Meaningful Use management product. This allowed us to track each measure on this sort of a dashboard. It was much more visual than the product that came with our Meditech software that we weren't super thrilled with. It just didn't look very nice when you had to give presentations like this. So we're happy I have this dashboard to show you guys. In this snapshot, I can show you how we monitor each item. You'll notice in this example, both the view, download, transmit, and the transition to care measures are red. This would indicate that those were not being met. If I wanted to, I could click on that and drill down into it. I can see which patients are in the numerator and the denominator, which is very helpful. So especially the ambulatory world, I can know ahead of time which patients are coming in. So I can target those patients and really make sure we promote the portal to them, try to get them on there. Makes it a lot easier to try to meet those measures. So our portal strategy, I'm going to talk about that first. Initially, we focused on our express care patients. We were trying to get a patient portal population that was easy to target. We thought during the registration process we can ask these people, are you interested in learning more about our patient portal? Yes or no, and then sort of follow up with them while they were in the room or shortly after they left the room. Initially, we were finding it hard to attract the attention of the patients during the registration process, probably because they're coming in, they're still in pain, and we haven't fixed their problem yet. They're probably not interested in hearing about what they can do after the fact. They really just want to be fixed. They want their pain medications, they want fix that broken bone, all that kind of fun stuff. So what we're starting to do now, or what we've started to do, we now have IT representatives visiting the patients either after they've been seen by the provider, oftentimes on their way out the door. So I think starting tomorrow we're going to have someone planted right outside the exit. So we're going to hit those people right as they're coming out the door, and hopefully we can garner some interest that way. We're still working on more clinician involvement. IT, we sort of view this as a transition period. We're sort of trying to transition, getting a workflow into place that the clinicians could then maybe take over. On our ambulatory side, we actually have clinician involvement. One of our practices, the physician themselves are promoting the portal to the patient, and they're one of our few practices that already meet this measure on the ambulatory world. We also have another office that did a sort of an advertising blitz for the patient portal, so all of the frontline staff were just promoting it at every point of contact with the patient, whether they're walking in the door, on the way out the door, when they room the patient. They were really just promoting that portal, and they also had a huge success with that. And they're the only other office in our group that meets that requirement at the moment. So it's still sort of a continuing challenge. I think we've got 15 offices that we still have to work on. Something else I just want to mention about our portal, one of our hurdles that we're still dealing with, the HIM and legal departments require us to verify identity with a government-issued photo ID before we can let people into the portal. So for our hospital, this is a significant challenge. A lot of people didn't plan to come into the hospital when their appendix burst, so maybe they didn't bring their pocketbook or they don't have their license on them. Even though they may be interested, we're having to say we're unable to sign you up at this time. So that's something we're still trying to figure out how we can deal with. How can we let them in there with a reasonable certainty to meet our, the legal obligation that that we have. So hopefully we'll have a new strategy on that soon. The best method we have found so far is to engage maternity patients after they've given birth. And then in that case, we're able to get both the mother and the child. So we've got 2 patients now signed in into the portal, which is fantastic. And the mothers, they are just so happy about that. One population that we found that's been very welcoming to the patient portal by nature, I guess. Also, due to some of the adolescent-specific regulation, we currently only allow patients that are 18 and over to join on the hospital side, with the exception of the newborns. And that's really because the proxy proxy access process for the patient portal is sort of confusing. So we're trying to just focus on people we know we can easily get on the portal. The patients also really seem to like the idea of having mobile access. It's a surefire selling point. When they say, oh, I don't really have a computer, yada, yada, yada. But I see that you have a smartphone in your pocket. Did you know that you could do it right from the smartphone in your hand? You don't even have to be on the computer. You can request your medication refills and schedule appointments and referrals and all that stuff. That does seem to be a big help. In terms of the VDT, the view, download, transmit, we really only focus on the V piece, the view piece there. Although the download and transmit pieces are available and they're functional for the patient, the way our portal is designed, if you can access the download and transmit, you've already hit the view measure. So we're really just pushing to get them in there, and we haven't really promoted the download transmit specifically. I'm going to switch to the transition to care over here for a second. So we're using a third-party product to create our CCDAs, even though we have the Meditech system in place. We purchased a third-party product to create the CCDA. We really liked this product from Iatric, actually, because it allowed us to completely automate the process. There was very little staff workflow changes we had to do for the end user there, which, of course, they really like. It's less clicking for them. However, until we're on the Mass Highway, we're still sort of limited in who we can actually transmit those messages to. Currently, we can really only transmit to patients that fall under our umbrella, under our Signature Healthcare umbrella, which is very unfortunate because it'll be really, really helpful and much more exciting when we're able to transmit to anyone else in the state. I'm hoping that will come soon. Let's see, but that's more of a vendor sort of limitation at the moment. Some of the other considerations that we had, we initially wanted to connect directly to the Mass Highway for both inpatient and outpatient. We wanted to bypass any other HIS. But again, due to those vendor limitations that were outside of our control, we made the decision to connect both the Meditech and the Allscripts systems into this third-party HIS, the MedAllies HIS. That allows us to at least transmit messages within our network. It seemed better for their care continuum since most of our patients, or a significant percentage of them, stay within our own network. So it didn't make sense to, sort of silo off our ambulatory practice where, we could now not send those messages from the hospital to the ambulatory world, after a patient's discharged, let's say, from the emergency room. That was, again, seeing that as was bad for the continuum of care. Excuse me, I lost my place. We briefly considered using the Meditech built-in portal for the inpatient side. Would have been much easier from a technical implementation standpoint. But ultimately, we decided we wanted one seamless portal for our patients. Plus, we had already gone live with the outpatient portal. We were really afraid that if we had more than one portal within our own network, that we would almost be competing for our own patients within our own network. Well, I know that you already saw, you're already on the Signature Healthcare ambulatory portal, but now we want you on the Signature Healthcare inpatient portal. It just didn't seem to make sense. So it's more of a technical challenge for us to implement, non-vendor compatible systems. But the vendors have been very willing to work with us on that, so that was very encouraging. Some of our longer-term plans are definitely to get on the Mass Highway. We want everyone to be able to send messages to us, and we would love to be able to send messages outbound to other providers. Currently, we're still doing that paper, mail, and fax. We already in it. The unfortunate thing is we have the Mass Highway land box. We have it in our facility and ready to go. We're just not utilizing it, with the exception of the public health measures there, like immunization registry. This is very unfortunate. We're also looking at engaging some outside expertise to assist us with a full EHR optimization. We want to make sure that we're really utilizing the systems that we have efficiently and effectively while still meeting the meaningful use measures. And myself, I'm constantly looking at those stage 3 proposals and revisions to see what else is coming down the pipeline here. I really don't want any more last-minute surprises from CMS. Those are just not as fun as you might think they are.
Great. Thanks a lot, Bill. I appreciate that perspective and for you sharing your time and experience with us. So I'm going to go ahead and shift over to our public health registries, and this is going to be fairly quick only because we've got a webinar for next month scheduled called the Insights into Massachusetts DPH Registries and Submitting via the Mass Highway. So this is a teaser for next month, so I would invite everyone to come back next month and hear from the experts at DPH and EOHHS specifically on each of these registries. But for your takeaway today, this slide will be included in the deck that we send out to everyone. You can see that there are a number of registries for Meaningful Use 2 that are available: immunization, electronic lab reporting, syndromic surveillance, cancer registry, and then DPH has designated their disease surveillance and case management system, MAVEN, as a specialized registry that qualifies for Meaningful Use 2. Just to further orient you to the slide, you've got the EPEH in whether or not there's a core or a menu for either of those, or if it is even applicable. You can see the status there, and I differentiate if it was made available just for, as an example, eligible hospitals, emergency departments for syndromic surveillance. And then the active path are essentially the path options that are available if there's an option for submitting this data to DPH. So let me do a final wrap up here around this world of HIE, as we've all alluded to, requires some interaction with organizations outside of your network frequently, certainly inside your network, but the real goal is to get outside your network to organizations you don't normally electronically. Certainly some things to consider, and this is kind of the finding a trading partner and best practices to exchanging section. So the first thing is, Meaningful Use certainly, in a way, prescribes certain things you need to do with an HIE over to meet certain requirements in the world of transition of care, view, download, transmit. But there's a lot of wiggle room for use cases within the world of transition of care. So think about what you want to do with your HIE to meet that requirement. Certainly, the Mass Highway is available, but as you've heard from our two guests, it's not the only way that you can do it. MedAllies is another HISP. The ECW has their peer-to-peer, and there's many other HISPs that are out there supported by different EHR products. So we developed a form that we trial and errored through our Highway Implementation Grant Program, where we knew there were a series of questions that were helpful in getting people to answer some basic questions to get started. And the basic questions are, why are you connecting to the highway, or why are you using an HIE? You could turn it into that. What is the scenario? What is the story you're trying to tell? Am I trying to go from a PCP to a specialist? Am I doing a discharge summary from a hospital? Who are your trading partners? This is a really important effort. It's good to know this before you start developing your HIE solution, because you have to know if they can be a good receiver. What systems or data sources are involved? What data is being exchanged? Are you sending or receiving, or both? If you're sending, can you create the data set? Can you generate that CCDA document? If you're receiving, can you digest the data set? Or do you know where to look for it if you are a receiver? So a form that is available to you, it's available on our website. You can click on this and I'll link it to you on our website under our use case tools section. I would encourage you to review your existing referral and care coordination patterns. If you're looking to find that trading partner, you know, we've had some people just as blankly say, you know, I just looked up the phone log on my fax machine to remember where I sent these referrals to. You know, wherever you keep a log of your referrals, your discharges, wherever it may be, is a good place to check to look for those particular trading partners, and then you can check to see if they're connected to an HIE and get that direct address. If you're using the highway, look to determine the status of your trading partners. We've got a new map that was just recently released and placed on our website of the trading partners where you can look at that status. And if your trading partner has not yet started their highway connection, I would encourage you, refer them to Health and Human Services, the Highway Ops team, to get connected. You click that link there to initiate that process. This is the map. This is available on our website. We're working with HHS to make sure that we've got a current status of all the organizations and their process of getting connected. You can see the oranges are those folks that are in progress. The blues are those folks that are connected. And then we have to do a little extra due diligence to go in and figure out if they're actually transacting for a particular use case. So some of the blues may actually be transacting, meaning they may be submitting public health information. They may be transacting a referral. They may be sending a discharge summary. And over time, we're going to get more of that information if they're willing to share it, and we'll include that in a use case library we have on our website. But as an example, when you hover over a dot, this one is Milford Regional Medical Center. You can see they're transacting, their location, and at least one of the use cases that they're transacting for. So please reference this, use this. If this helps you find trading partners, that's really wonderful. And if you have feedback, let us know. I want to introduce a concept of exchange etiquette. So as we start embarking in this world of HIE, there are some rules of the road, or perhaps not rules, but they are courtesies that we should extend to our trading partners. And I think it's important to recognize to send a message to someone who is not expecting it is probably not an appropriate use of an exchange. So it's important to do your prior coordination, just as you would find the point person at another facility before you send it via fax or by courier or whatever it may be. It's important to do the same coordination, prior coordination, before you send electronically. And as the highway directory becomes more full and more organizations get connected, you'll have a greater access and ability to just send messages. Please, we really encourage you to coordinate with your trading partner so they can expect and know to look for that particular document. Not everyone's HIE infrastructures are fully developed where they have these wonderful triggers upon receipt and population in their EHRs. It really is a maturity process we're going through. And then finally, everyone wants to be a sender, but we also need receivers. We need people that can receive documents out there and to be able to send the proper acknowledgements back. So please play well in being a sender and a receiver if you're able. And we're looking for, obviously, greater diversity of participating organizations. So we have a decent diversity now. We're working on improving the volume of that with our colleagues at HHS. But if you are a long-term care facility, behavioral health, acute care hospital, small practice, large practice, you know, we welcome all types, and we'd really encourage everyone to get on and join the highway, and then certainly other HIEs as well.